in the whole healthcare setup, I mean, we usually see the way of hierarchies. It's like the doctors, the nurses, the physiotherapists, the pharmacists, all that. But ideally, actually, we need a team approach in the healthcare. I'm proud to say in Canada and the Western countries, we have that team approach very much here. We are seeing that now growing that idea in Sri Lanka too. In that context, we have another great resourceful person here. She's a pharmacist and she lives in Vancouver. She is the Provincial Pharmacy Education Coordinator for British Columbia Cancer. She coordinates and delivers education programs for pharmacy staff at the regional centers of BC Centers, BC Cancer, undergraduate and graduate pharmacy students and pharmacy residents. She is an expert practitioner in oncology pharmacy practice. She is also responsible for the BC Cancer Oncology Pharmacy Residency Program, one of 2 oncology-focused programs offered in the whole Canada. In addition, she currently maintains a direct patient care clinical practice in breast cancer. I can read the whole thing. It's going to take another 10 minutes, but please welcome Fatima Lada. She is part of our team for the past over a year, and she is a very resourceful person. Welcome, Fatima. You have 10 minutes for your presentation.
Thank you very much, Rara. I appreciate the opportunity to speak to everyone today. Sorry, just give me one moment. I'm going to figure out how to share my screen. Desktop. I don't know if anyone can see my screen right now. No.
So first you open your presentation, then click the share screen and click that particular presentation and highlight, click yes.
There we go.
There you go.
How is that? Got that? Okay, excellent. Okay, so I was asked to speak a little bit about pharmacists in healthcare. So I thought I'd do a quick presentation on how we are your drug therapy experts. So to start off with, what's the definition of a clinical pharmacist? So it's someone who has in-depth knowledge of medication and disease states, managing medication therapies, and we have direct responsibility and accountability for patient outcomes. We can be a primary source of scientifically valid information for the use of medications that are safe, appropriate, and cost-effective. So pharmacist training, it's now 6 years of training where the undergraduate program is actually a Doctor of Pharmacy with additional training available for pharmacists, residency training. We have postgrad year 1 general practice in ambulatory care and hospital care. And there's a postgrad year 2 program available now in specialty areas, critical care, palliative care, oncology, infectious diseases, etc. There's also opportunity for fellowships in academia and research. So what exactly does a pharmacist do? We collect, assess, plan, implement, and do follow-ups. And it's collaborative, you're utilizing communication, and we're documenting. And it's very patient-centered. So what does a clinical pharmacist in palliative care actually do? Well, and there's a lot of roles. I tried to figure out how best to characterize it, and it felt like I was going to be an octopus with 8 arms. So I thought I'd just list it out a little bit. So one of my roles is drug distribution. I will be involved in compounding non-commercially available products, specifically when asked for supporting malignant wound care, any neuropathic pain, topical treatments, oral compounds for a condition called mucositis. I will be asked to determine which drugs can be given by feeding tube for patients who can no longer tolerate taking medications by mouth. So can the medication be crushed? Can it be sprinkled? Is it stable? What considerations do I need to have for storage? Is there a liquid formulation available? Is that commercially available, or is that something I need to compound? Safe storage of medications when considering temperature and humidity, that can be significant, that can significantly impact the efficacy of a medication. Drug compatibility, especially with intravenous and subcutaneous medications. Will the medication crystallize before it goes into the body and thereby causing sequelae of concerns that may end up causing harm to patients? Access to durable medication equipment and supplies when patients require infusion pumps, nebulization for inhaling medications. What kind of tubing is necessary for medications? Also, drug recalls and shortages, especially now with our global crisis of medication shortages, it's going to be the pharmacist who will be able to advise you what recalls there are, what shortages there are, how much medication is available to continue accessing for your patients. I'm also involved in optimizing drug therapies. I'll evaluate the symptomatic complaints of the patient and recommend appropriate drug therapies. Within that, I'll recommend new starts of medications, switching routes of treatment. If the patient's unable to take oral medication, can we now give it to them intravenously? Switching different therapies, can something be rapidly tapered or stopped? And how to do this safely, because one of the concerns for many medications, especially in palliative care, is withdrawal, and in some cases life-threatening withdrawal for these patients, which would cause harm and reduce the quality of their life in their remaining days. What are cost-effective choices for drug therapies as well? I have the ability to refer patients to appropriate patient care services, dietitian, social worker, physiotherapy, occupational therapy, religious supports through chaplains, imams, etc. I'll be able to prescribe therapies in collaborations with physicians, anti-infectives particularly, antibiotics, antifungals. Opioid rotation is a big one, especially in palliative care when formulation of drug therapy needs switching. Again, patients are unable to tolerate oral medications and require much more comfort with intravenous or subcutaneous medications. Prescribing adjuvant pain medications, various drug classes as well. I have the ability to independently dose adjust medications for toxicities and efficacy. I have experience with cardiac medications, anti-epileptics, anti-nauseants, blood thinners that are required for preventing harmful blood clots. Basically, our job includes identifying drug-related problems. So these are the major classifications of drug therapy problems that a pharmacist will look for. Is there an indication? Does the patient actually require drug therapy but not receiving it? Is it the incorrect dose? Is the dose too low? Is it too high? Is it the wrong drug? Is the patient not receiving therapy as they require? Maybe they're not taking their medication. Is there any adverse drug reactions that are preventing the patient from being able to receive benefits from the drug therapy? Are there drug interactions, whether it's with other drugs, with foods, with laboratory parameters? And my job also includes resolving these DTPs, making recommendations to the collaborative team, independently implementing these changes to resolve these DTPs, and then establishing the monitoring plans and following up alongside the team or on behalf of the team. So within patient safety umbrella, my job includes investigating medication errors. I'll analyze the trends, and I'm participating in plans to prevent, correct, and resolve these medication errors. There's a seamless care, and medication reconciliation has become a big component of healthcare cost reductions throughout the world. So that requires educating and auditing staff for safe practices, hospital admission med reconciliation, discharge med reconciliation when patients are going home, and then developing and screening processes for drug misuse. Drug diversion can be a problem. Fentanyl patch, return procedures, establishing compliance packaging or blister packing for patients. I also have a role in drug information and education. I'm responsible for staff education, hosting rounds, journal clubs, in-services for various care teams. I can advise medical providers of off-label indications and evidence-based to support the practice. This is especially important in palliative care where we don't have a lot of strong evidence-based publications, and we're relying on case reports, observational studies. The evidence isn't as strong, but it's absolutely necessary for our patients. So how can we apply this information safely to this particular population who's very vulnerable with lack of resources at times and lack of advocacy in many ways. So that requires knowledge of general and critical care medicine, critically appraising literature evidence, maintaining these standards that we would apply to general medicine practices into palliative care. And the biggest quote that I remember learning from one of my professors in university and throughout the years is being comfortable with the uncomfortable, identifying the information for your patients and advocating for that, and doing so in a responsible manner. With patient and family education, I will be participating in drug therapy counseling during patients' hospital admission, during their stay, and at discharge. I'll participate in family meetings to address any myths, concerns, misconceptions. There may be fears of risking addiction, drug abuse, drug diversion, and overdose. For example, the biggest impact I think we've had recently is the opioid crisis globally on access to palliative care treatments. And as a pharmacist, I feel it's my role to advocate for patients' access to these medications by diverting those myths and clarifying any misconceptions, addressing any concerns for patients and their families. Complementary and alternative medication. This is very big in many communities. So how can we integrate Ayurvedic medicine, Chinese herbal medicine, naturopathic therapies into the patient's care and respecting their needs, their desires, their beliefs into their overall care? And as a pharmacist, I'm able to support this. I'm also involved in administration and formulary management. So developing and maintaining drug formularies utilizing current literature, best practices, and performing pharmacoeconomic analyses, cost benefits, etc. I participate in pharmacy and therapeutic committees. So I look at drug use evaluation, and I'll even create drug monographs that are patient-specific or area-specific based on the needs of the population. Medication-related quality improvement projects. I've been involved with antimicrobial stewardship to reduce the risk of resistance to antibiotics and anti-infectives in our society, basically. Opioid stewardship, appropriate use of opioid therapies, and making sure that these medications are used safely. Involvement in polypharmacy using medication reconciliation. Within palliative care, I've supported and helped develop optimizing medication use for bowel care protocols, nausea protocols, febrile neutropenia. There was also an actively dying protocol that we implemented into long-term care and within home care environments for community use. So I thought I'd look a little bit into where is money being spent in 2019 for healthcare, because as we know, healthcare costs are increasing for everyone all over the world. So I didn't have data specifically for everywhere else in the world. I was able to collect data for Canada and the United States. So I thought I'd share that and kind of put it into a little bit of context. So within Canada, it's estimated in 2019 that $264.4 billion will be spent on healthcare in Canada. And that averages about $7,000 Canadian per person and accounts for 11.6% of our GDP. That's significant, and that's been doubling since 1999. So in the last 20 years, we've seen that kind of growth. Within the US, it's much higher. It's $528.4 billion per year. And that money is being spent managing treatment failures, medication-associated injuries, all of which cause hospitalizations and may cause increased care requirements for patients after they resolve or try to resolve these medication-associated injuries. Medication non-adherence, not using medications, it has an economic burden of close to $100 billion a year in the US. And even though adherence to medication leads to increase in spending, there is an overall reduction in medical costs elsewhere with hospitalizations and utilizing needs for specialists, etc. So within palliative care, how does palliative care fit in within healthcare costs? Well, 25% of total healthcare spending is actually in the last year of life. And within that, 40% is spent in the final 4 weeks of life. So that ends up working out to 10% of the total healthcare budget, whether it's Canada or the US, the number of 10% is about the same. That's a huge cost with palliative care, and that's something we need to focus on because there is need for access to palliative care. And as Jonathan has mentioned previously, there is access to care is a problem. So why does it cost so much? Well, patients don't take their medications. Prescribers will not follow the guidelines necessarily. There's medication-related adverse events or mortality. There's overprescribing. And then there's gaps in transferring patients from hospital to home, resulting in hospital readmissions. So expanded pharmacy services, there was a study done by Perez et al. In 2008. They looked at 93 studies published between 2001 and 2005. They observed the economic impact of clinical pharmacy services, whether it was in hospital, ambulatory care clinics, nursing homes, home health care. And they identified for every $1 spent by hospitals or healthcare systems to provide clinical pharmacy services, $4.81 was saved by incorporating pharmacists. And those costs were saved from lowering overall drug costs expenses, reducing adverse drug reactions, reducing medication errors, and overall reduction of hospitalizations. So why should pharmacists be included within your healthcare teams? Well, it's obvious that we save cost on preventable adverse reactions. We have reduced associated healthcare resource consumption, for example, related to hospitalization. We can even reduce the pressure on physicians with complex patients. We'll bridge the gap of pharmaceutical care through that continuum. So patients coming into hospital and then going home, making sure that there is no gaps within their care. We can help further optimize medication uses, and we implement evidence-based therapies at the same time. So how can pharmacists be included within healthcare systems? Include them within your collaborative teams, establishing shared space with the rest of the team so it's centralized, inviting pharmacists to participate in patient care rounds, inviting pharmacists to join home health visits, whether it's collaboratively with other team members or independently. Maybe establishing a referral or consult service for pharmacists where we can do deprescribing or address polypharmacy. In cases where chronic disease management is required, we can support that. Looking at adverse drug events, helping with any new patients and diagnoses. One of my favorite phrases that I'll tell physicians is, tell me the diagnosis and I will figure out the treatment plan for it, basically, right, when it comes to the drug therapies. And we can also help reduce the burden on the entire healthcare team by answering questions and providing patient education around medication therapies. There's also suggestion with co-locations or satellite pharmacists within patient communities, as we've experienced when the home care team has to travel so far to go see individual patients to answer questions and adjust drug therapies and assess patients. Maybe pharmacists can actually be located in those communities and reduce the impact and the burden of those costs of the entire team traveling to those sites. Thank you.
Thank you, Fatima. Fatima is one of our valued members in this Northern Palliative Care team, and I fully acknowledge that any palliative care team every palliative care team should have a pharmacist as one of the members, and that really helps and make things improve. And I could imagine somebody like Dr. Madhurahan sitting in a very remote place in Vavuniya, and then he is doing his questions, and Fatima answering from another extreme of the world, Vancouver. This is happening thanks to the technology, and thanks to you, Fatima. She's always there with us in our rounds, the monthly Zoom rounds, and her contribution is, I have no words to say that. Thanks again, Fatima.